Good job. Okay. You ready to go?
I'm ready to go. This is my keyboard.
Tell me, how many reviews did you see this time?
No, I only saw one. I saw the one that you did, and
Okay.
that was the one I was able to make.
Okay, that's fine. That's fine. At least you got to one, and that's what I want to hear. At least you got to see it.
Hearing you on YouTube, like on repeat.
YouTube repeat. You know, I have pulled it up for my grandson. I said, "Look, I'm on YouTube." It's like, wow.
What?
But I put not for kids, so he can't get to it without me. So.
Oh.
All right. So Sylvia, you're good. Mia, you're good. Ulysses, what do you got for me?
Yes, here.
There you go. Thank you so much. And do you have your black whiteboard? What do you have? Beautiful. Thank
Let
you
me
so
log
much.
in my phone.
Okay, make sure that you have your exams downloaded. And I do need a side view when you're ready, okay? Amber. Your camera's off. Where are you, dear?
Yeah, my camera's off. I'm not ready. I was cleaning up.
Okay, when you're ready. When you're ready.
I was cleaning my desk. But here, I can give you my ID.
Okay, good job.
And I can show you my computer area.
Good job. All
and
right.
Here's my whiteboard.
Good, thank you.
You're welcome. And I watched your review too. So I have found of all the reviews, I guess because I'm in your class, so I understand it so much better.
Okay. You know, everybody has their own thing. It's okay.
It's true.
I mean,
just appreciate
there's some professors that some students like Diane Gullett. She actually gives a great review too, but described a little differently. And that's what I like about us. We're all different, but we're all are very knowledgeable on the topic.
Oh, absolutely.
So,
I just have found that the way you give the stories and you tell, I remember them. So I can go, oh, I remember that story. So
and I got a lot of stories.
And I love it because I'm looking at getting into peds oncology.
There you go. You're going to get those big bonuses as you go along.
Yeah, well, actually, you're the one that put me to it. So
there you go.
Yes.
It is a great field. It is hard. It's heartbreaking, but it's so rewarding.
Yeah.
And just always remember, it's not if they live or die. It's what you did for that family and that child while they're alive. Because not everybody's made to live forever.
Right.
Old, young, don't matter.
We just never know.
I mean, I cry. Why not?
Oh, absolutely.
I heard they're my kids in the hospital. That's what I used to tell the parents. It's my child.
Yeah.
And after a while, they say, yep, they are. You're absolutely right.
Oh, yes.
All right, we're doing good here. Let's see. Exam 2, let's publish you.
Professor Bogart, are you gonna put the password in the chat later?
The what?
The password, are you gonna put it in the chat when we all start?
I do the password and then I will put the password in the chat. Absolutely.
All right, I just wanted to make sure that I wasn't like not seeing it yet, so.
No, not yet. That's everybody gets there.
Thank you.
Oh, you're welcome.
Perfect. Ready.
That's good, Ulysses. Now, do me a favor. You see your screen? I want it a little bit tilted away.
Soda. I need my water
Oh,
bottle.
no, you're good. All right, it's the other computer. Never mind. You're good. So, Nicole, do you have your ID, please?
Yes, ma'am.
It's on your chest.
Oh, that's my, sorry.
The other one. Okay. Thank you. And you have a whiteboard. What do you have?
I have a white piece of paper.
Okay. Remember, next semester, they're not going to accept it. So get yourself prepared for that in your travels. And just a A plastic page protector, you can use that and erase it. You don't have to get a whiteboard. So
Okay,
those are actually easy to find. They're all over the college if you ask. Okay.
okay.
Yenisei, did you miss any reviews at all? Just one. You know, I put the last two numbers backwards.
That's okay.
Sorry.
I see the recording. That's okay, Professor.
Yeah, but I did get it up after that pretty quick.
I'm sorry. Professor Hernandez, the other day, she was waving at you, but you don't see her.
Oh, I didn't. I love Yvonne. You know, I mentored her for her master's. Yeah, we're very, very close, very close. I love her. I love the way that she teaches. I think she's smart. She has a great heart, and you don't get a lot of people like that. So, yeah, I absolutely adore her. I do. So, you had to say, give me your ID for me, please. Good job. And you have your whiteboard. What do you have? Good. You're ready to go. Good job. So far we're good. Let me see. You guys are. I just ordered my second set of antibiotics for this that's going on. And
Oh,
a
wow.
long course of 20 milligrams prednisone for a week, a steroid inhaler, whatever, which one, I don't know, and some different cough medicine. So this is continuing. It just doesn't stop.
Mm-mm.
You know, I'm negative COVID, influenza A, B, negative RSV, but
See, my community teacher, or not my community, my med surge teacher, she was really sick and she went to the doctor, and the doctor in Virginia said, we are not testing adults for RSV.
well, they did. It was part of, actually, they told me it was one strip that had all of them. I was like,
Oh.
what? Because it's working in an emergency room, it was influenza, was different from RSV, different. So they were all different. But now they have one with all of them on it. I was like, whoa.
That's cool.
Yeah, yeah. I mean, we know that RSV on adults is a common cold.
Correct.
We know that it doesn't affect us the same way, although this season it is stronger than previous seasons. The RSV is pretty bad this season.
Oh, absolutely. It's horrible.
Yeah. Well, it looks like everybody has their exams downloaded. That's a good thing. Only Megan when she comes. All right. So some of you were in community before this one, correct? Yeah.
Yes, we were in community.
And it does sometimes run over. Yes, I know.
And the president was there. Darlene, I think.
Oh, she was in there monitoring it.
Yes.
What she does is she actually did it to my last Monday class. She wants to see if your students, if you as a professor incite your students to be able to ask questions, to be able to answer questions, to see if you're understanding. So it's part of our annual evaluation. Okay, who is a Zoom user? What is your name so I can put it in?
Oh,
for you?
I'm sorry. It's Amoy McNeil.
Okay,
So sorry.
and not a big deal. I can take care of you. I just learned how to do this last semester. It was Professor Morris that taught me. Because I don't know everything.
we'll have class after the exam, right?
Yes, you will.
Okay, perfect. Just wanted to make sure. Thank you.
Why didn't you just show up? I just put you in. Oh my God, you know what I did? Somehow it changed. And Yenisei, I made your name somebody else. Sorry. And then let me get you. Sorry, Yenisei, I didn't mean to do that. I gave you a new name. Now I gotta figure out how to spell your name. Y-E-N.
Y-E.
S-E-Y.
Mhm.
Salazar.
Salazar.
That's easy. Got you. Good. Okay, so Emily, please give me your
Yes.
ID, please. Beautiful. And you have a whiteboard. What do you have?
I have a whiteboard. No, a paper.
Okay, and just give me your side view, please.
Sure. Let me know when it's good.
Megan, did you download the exam?
Just now.
Okay.
I'm gonna
good.
download it now.
Okay, Victoria, can I have your ID, please? Okay, thank you. And do you have your whiteboard or paper? What do you have? Okay, good job. Raina, let me see your ID, please. Okay, good, thank you. Do you have your whiteboard? Oh, with a heart, I love it. Who put the heart there for you? A kid?
My daughter.
Oh,
You see, I knew it, had to be.
I'm about to do my
Okay, Megan, your
Do not
ID, please.
my ID.
Okay, do you have your whiteboard?
Yeah, it's the only whiteboard I have.
It's a huge one, that's okay. I saw
It's
one
like the
even
weekly.
today. I was like,
It's
oh
like the
my.
weekly one.
Just give me more of a side view of your desk. The way Mia is good, Sylvia or Yinsei, those are good. Victoria, they're good. Crystal, your ID, please. Okay, do you have a whiteboard? What do you have? Good. Now, your background.
Let me just change my camera. It's on blur. Hold on.
Yes.
Because I'm sorry.
Good, I was just gonna say that. Good job.
Let me take that off of there. Just realized I can't see a thing. No. Okay. ID,
Yep, I got it.
whiteboard.
I got it. And give me a good side view. Okay, good. Now, remember, I don't want to really see your screen there.
Huh?
That's good. I really don't want to see your computer screen.
Okay.
Do you know why I don't like to see computer screens?
Why?
When we
Well-
first started doing Zoom, students could pin in on the Smart Kid and would be cheating by looking at the answers.
Oh, well,
We don't
Makes
want to
sense.
do that. We want
Oh.
to make sure that you're learning, not just
Okay.
learning how to cheat, right? Because some of you might be taking care of my grandkids one day, you know, so, or me. So we want to make sure that you're learning, not just getting by. Beautiful, Crystal, perfect. 3, 6, 9, 10, 11. So we're just waiting. Celia is left, right? Megan, Ulysses, Crystal, Victoria, Moy, Amber, Rena, Sylvia, Nicole, and Jade is not going to be here. That's fine. All right. Celia will come in and we're going to have to put her on mute. All right. What I'd like you to do is first take a deep breath. In and out. I know you guys have studied hard. You are a great class and you always do really well. So I wish you really good luck. remember to read the questions. There are questions that you think you know the answer. Go back and make sure you answer what it's asking for. Okay, so make sure once you try to figure it out, look at what is the, am I really looking for, okay? I want you to take your all off of mute and I will put you on mute. We will come back at 9:15. Nico, you gonna say Mia?
Yeah, go take a shower.
It's funny, I put you the same name. Victoria, could you please get off of mute too? So I'll put everybody. Nicole,
Yes, sorry.
all right, we're gonna mute
No, no
everybody.
mute, no mute.
You are, everybody's on mute now. Remember, from now on, if you need assistance, please go through the chat box. You know, I turn my camera off and I turn my microphone off. If you need me, I am here. I'm not going anywhere. Just send me a message and I will get back to you as soon as possible. So the first thing I want to do is, Mia, I'm going to send you a code. It is only yours, all right? And then I'm going to get the rest of the class. Mia, you may start. There is your code. The rest of the class, remember, be back at 9:15. I do not need to see that you've downloaded, okay? If I have a problem with your download, I will let you know there's a problem with it. So here we go. Little I, big J, big V, number 7, big G, little d. Again, little I, big J, big V, number 7, big G, little d. If you need an access code, please, I want you to send me the code they give you on the computer, and that's how I get your access code, okay? Good luck, everybody. I'll see you all at 9:15. Okay, Crystal, I'll see you at 9:15. Thank you. Perfect. You did great, Mia. You did great. I can't tell you a score. You did good. Really good. So
Thank you.
breathe, just breathe. I can't tell you a score, but you did really good.
Okay, thank you.
You're
As you
welcome.
can see, I've got chaos going on behind me at the moment.
It's okay. I love chaos. I love children. You know that. I have no problem with kids. I love them. I'll be happy
It
to be
was
back
just
in
one
a
of those-
couple.
They had like a trail life, which is like Christian Boy Scouts kind of, and they had an award ceremony. So they came in showing me all their awards, and I was like,
It's okay. Kids are awesome. Enjoy every moment.
I do. I love them to pieces. My sister and I live together. We're both single moms, and we love it.
Oh,
it's
that's
amazing.
awesome.
Yeah.
That is
It's
great.
And
then
last
you-
weekend we had 6 kids every night at the house just because.
Listen, I always had kids and I was a single parent alone. I
Mhm.
always had the neighborhood at my house.
Yeah.
I always had extra kids staying over, eating dinner, and that was just who I was. So
Yeah.
I get it. I totally get it.
Yeah.
All right,
I would
I'll be
way
back
rather
in a
have
couple
them
minutes.
here.
Let me go run. I have to go to the ladies' room.
Right.
I just got done with the exam. Everybody's
okay.
done. So then I'll be back with the cahoots.
Sounds good.
Awesome.
I'll work on my math.
There you go. So tell me, how was the exam? Any surprises? Okay. And Mary, you were way up there, so don't worry. Because I know you. You're like, no, you're awesome. Don't ever second guess yourself. You're awesome.
One of those math questions was good and just a smidge tricky.
Oh, the 24 hours one?
Uh-huh. We got into
I
a big
said-
debate about that in my
That's why
med
I
class.
said, make sure you go back and read it. That was probably the one that I'm like, make sure you read it, because that question is gotten wrong because you don't think of what's per dose, it's per 24 hours. So yes,
Mhm. Yes.
yes. Again, I mean, it's a simple question, but because it's not like what you think you're supposed to do, students get it wrong. They do. Wait a couple minutes, see who comes in. Victoria, you did good. Don't worry, you passed. Every person in this class passed. Every
I
person.
was very nervous, teacher. You know what? I was very nervous because my granddaughter came in the room, then my husband, then my son. I was doing like this. And then the dog was barking. And then
You did good.
I
Don't worry.
I gotta read the question, like pronounce the question like 2-3 times so I can understand. And oh my God, I was like, oh my God, I'm so scared. What am I gonna do?
You did good. Don't worry. Everybody passed.
Good.
Everybody passed.
Wow, that's nice.
I want you to know in this class, I never have issues with this class. The mean score was 91 in this class.
Wow.
Yes.
91.
Congratulations.
From 80 to 100. I can't tell you what your score is, but everybody passed.
Yes.
Thank you.
And
That's
it's
great.
everybody passed. Mean score is 91.
Wow.
There are 13 students. It's a small class. We know that. But you guys are amazing. All of you are. The
I
other
think
classes
that
are about
the Kahoot
85.
help us a lot.
The Kahoots?
The
If-
Kahoot.
Yes, if you read the Kahoots, then listen to the way I describe them. It makes you understand it. And not only understand it, you can apply it in many different ways.
Yes,
And
that's
that
true.
is my goal.
That's true. Thank you, teacher.
Professor,
Welcome. Yes,
after
my darling.
Saturday, can I ask you one of the questions from the exam?
You
because I
got
was
one
confused.
question wrong. You got to get on the child's developmental level. Yeah, and you know the question. I already looked. That's the one.
That was the last one. I was, oh my God.
I knew you'd ask, and I had to tell you. I mean, you're my 100 girl. You always get 100, so I had to like divulge it.
Thank you.
All right, let's get going. So, who wants to win this one? Now, it is Cerebral and Endocrine. And I know everybody's looked at the interactive PowerPoint before coming. Yeah, I know. I'm realistic. I'm not dumb. But I know that some of this you've covered in already MedSurg. So let me see if I can describe it in a different way that helps you understand it a little more, okay? Because I make it simple. You know that. I mean, DKA made simple. That's rough, huh? I could do it. I believe there's 48 questions. Who else is joining me? 1, 2, 3. I need at least 5. 5 or 6. There we go. All right, we're going to start it up. Let's get it going. Week 7. Remember, there's discussion, question, due Wednesday, okay? That's your assignment this week. Growth hormones is administered by what route? Now, in children, you got small children that the parents aren't. So the kids are just small, probably due to an undersecretion of a growth hormone. So they get this until they stop growing less than 1 inch per year. And you're going to see kids do get big, but it's a subcutaneous injection. So this really takes a lot of determination by the child and by the parents. And usually those are those 12-year-old, 13-year-olds, they learn how to do it themselves many times. Highest priority for a patient diagnosed with syndrome of inappropriate anti-diuretic hormone. Well, let's look at what the name says. Anti-diuretic, against diuresis, against urinating hormone, right? Let's make it simple. When you think you're not urinating, what do you worry about? Well, retaining fluid. So intake, output, and of course with children, daily weights would be the other thing. Good.
Edema.
Oh, edema, swelling, all of the above, yes. And what are we going to do? Limit fluids, we're going to watch salt, and we are going to, watch this child very closely for congestive failure, right? Which of the following are signs of a syndrome of inappropriate antidiuretic hormone? It's also called SIADH, easier for me to say. Again, too much against urinating hormone in the body. What's opposite? Diabetes insipidus. It's too much urinating. This is the pituitary gland, the posterior lobe. Too much or too little? Well, if you're not urinating, what are you going to see? A decreased urinary output. All the other, no. So inappropriate against urinating, not urinating, decreased urine output. What is important to cover when teaching the family about propithiazole? This is a medication given for hyperthyroidism. And we need to teach our families and child about what are these possible side effects. This is different. And the other name is PTU, is the way that I was taught, and I've seen a medication delivered. But PTU does cause leukopenia. Not enough white counts, what does it cause? Well, it causes, you don't have white cells, be risk for fever, infection, sore throat. So these children and the mother or father need to be taught. Your child's starting to have these symptoms, they need to call their doctor. Is it a virus or is it a side effect? I'll multi-select. An initial sign of diabetes insipidus. Again, posterior pituitary gland. Is it too much, too little? What is it? I've said SIADH is you're not urinating, but diabetes insipidus is the opposite. It's the P and the P. There's not 3 Ps with diabetes insipidus. Most common mistake made by students. Polyphagia? No. Has nothing to do with eating. No. It is you drink, 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 urinate, urinate, urinate. And you need to get steroids in order to stop this. And it's for life, checking on this. Infants, we detect diabetes insipidus because they cry, they're hungry. We feed them milk, whether it's breast milk, formula, and they drink it, and they're not satisfied. Give them a bottle of water and they're fine. It is, I've seen it on an infant, and it's like, oh my goodness, a bottle of water solved this with this child. And I work nights, so I'm trying to put them to sleep. I'll multi-select. What are the clinical manifestations of juvenile hypothyroidism? It's exactly like adults, except for one thing. What's the one thing we always worry about with children? Nutrition, 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 and cognitive, being aware, right? But children, they have that dry skin, thinning hair. They even call it like sparse hair. You know, it's not like the normal thick hair it should be. Constipation, cold intolerance is one of them, just like adults. But in children, they're not going to have the growth. And if we find this out as a newborn, we need to replace that hormone as quick as we can, because you'll have cognitive delays, okay? Constipation on a newborn. If they don't stool in the first 2 days, this is one of the diseases they'll be checking them for. What do they check for? What is thyroid? T3, T4, TSH, okay? A child's had a simple febrile seizure. What education will you provide to the parents? I mean, children can have febrile seizures. And remember, it's not like it's a tonic-clonic, need seizure medication type of seizure. Issue where no fever, 20 minutes later, you have a high fever, and your brain sparks and said, oh, I can't handle this high temperature, and you have a fever. Any seizure is safety. And what is safety? What would you as a nurse do? Whatever the cause of the seizure, you want to put the head of the bed down. You want to turn them on their side in case they vomit. You want to check their bed for any sharp objects. And if you can, pad those side rails, because they'll get in between and they'll bang themselves, okay? So one febrile seizure does not make epilepsy, okay? And parents need to hear that. My firstborn grandson had febrile seizures at 18 months. What type of seizure is it? When the body is jerking, foaming at the mouth, and the child is rendered unconscious. That's your postictal. They don't remember what happened. It is called tonic-clonic. Very good. Absent seizures are like when you do those blank stares. Tonic-clonic jerking, that is the one that we think about when we think about seizures and protecting them, of course. What notable sign may indicate increased intracranial pressure in an infant? Now, they can't tell you they have a headache. They can show you vomiting. But what else? And once you see this in an infant, you don't forget it. It stays in your brain. And it's called a high-pitched cry. You walk into a room of 20 infants and one is a neuro kid. Increased pressure. That cry is like nails on a chalkboard. You will never forget it. You're like, oh, that kid is neuro. And that's increased intracranial pressure. The other thing, when you're doing an assessment, you might see a bulging fontanelle at rest. Sitting there, sitting up in a, like a little chair type thing, and they're asleep and their fontanelle is bulging. That also is showing you. Fontanelles tell you a lot. Looks at fluid balance, and it can show you pressure in the brain. All of the following increase intracranial pressure except what? Now we're going to be taking care of these children. And, working in the PD ICU, they had a fall. I've seen them fall off a second story of balconies onto their heads. I mean, I've seen it, and they just need to be hospitalized, but they do have increased intracranial pressure, right? So taking care of them, we have to be careful of turning them only when needed, preventing them from coughing, which means if they're intubated, we're going to do it as infrequently as possible. And of course, suctioning, you're gagging them, it's going to cause it. But the heart rate has nothing to do with increased intracranial pressure. What findings can alert you to a head injury getting worse? So we know we've got a big, bruise on the head. They fell off the roof of the house, because kids do this stuff, and they're admitted to your floor. What are you going to watch for? I mean, kids come in from sports injuries and they ran into a defender's knee and they were knocked unconscious, brought to the ER to be visited and looked at. They're going to ask, so was I safe? Was I safe? Did we win the game? Is daddy coming? And you've answered these questions 16 times already. That's a change in orientation. It's an increased restlessness. It's a headache that's getting worse. And it's a difficulty to arouse. So the other three answers are the opposite of what you would see. A multi-select. What does it mean when you see a fixed and dilated pupil after a head injury? I mean, we check neural checks, right? We check pupils. Why? If we see it fixed and dilated, what does that mean? That means I need to call the doctor right away. It's a neurological emergency. Probably there's extra blood getting into the brain. Probably they need to do some sort of craniotomy, an evacuation of the hematoma. Something needs to be done, because if we let that sit there like that, it's a brainstem injury and it's irreversible. So these children will be nothing more, literally, okay, because their brains will be gone. Which of the following signs and symptoms are more common in children than adults following a head injury? On Saturday, my grandson went in my backyard, was trying to sit on my bicycle on the handlebars, fell off, and you see that lump? He had one of those. I'm like, kid, what are you trying to do? Test my knowledge here? Well, what I was looking for, and I was feeding him his favorite dinner, which is spaghetti and meatballs. He ate it, did well, didn't vomit. I'm like, okay, I'm safe. Nausea and vomiting you see in children. You do not see that as frequent as in adults. Usually it's just kids. What medication may be used for a child with cerebral edema due to a fall? So whenever you think of swelling in the brain, we want to get rid of the fluid. Well, what diuretic is specific to the brain? Think about pharmacology. Mannitol. Only mannitol is for the brain. Furosemide is always due to peripheral edema or congestive heart failure. Phenobarb is a sedative used for mostly, and phenytoin used for seizures. So mannitol. Remember that one. Very important concept. Diuretic for the brain, mannitol. Ray's syndrome. What's that? So Ray's syndrome is due to aspirin, right? And it's metabolic and it's in children. The only time we give aspirin to children is Kawasaki disease. And do you remember why we give aspirin to Kawasaki disease? Because it thins the blood and prevents clots, and it's an anti-inflammatory. That's why we give it, and it's high dose along with that intravenous immunoglobulins. Good. Febrile seizures usually occur in what? The best thing about febrile seizures, they do grow out of it. You know, my grandson was 18 months old, and my daughter-in-law was like fanatic with a thermometer 16 times a day. He's now 10, and she needs to stop taking his temperature, because usually it's about 6 months to 6 years of age is when you see febrile seizures. And parents need to be told, you need to walk with Tylenol and Motrin and a thermometer, and you need to take it as frequently as you think, because it is scary. I lived through it with my daughter-in-law, and it is frightful to see them having that seizure. Childhood hypopituitarism results in what? You know, the pituitary works with your fluid balances, SIADH, works with diabetes insipidus, but the anterior lobe has to do with growth, right? So if we're hypo, you're not getting enough growth hormone, so it is pituitary dwarfism. How would you describe precocious puberty? You know, if you go back and you look at the book and you look at precocious puberty, they say 7 years old, when you reach, you know, go into puberty, that's young for a girl. But remember, boys go through it too, okay? And boys would have hair on their chest, you know, and go through those different pubertal changes. In African American, they say 6 years old, but it's getting to puberty early. There is medication, it's called Lupron, that they give. And what it does, it stops puberty from happening until when it should. And the book says 12 years old and 4 months is the average age that you should go through puberty. And you know something? It was exactly that for me. I remember, because all my friends got it before me. I thought I was, you know, wrong. I wasn't there. Multi-select. What lab values are important to monitor with a child with congenital hypothyroidism? So you have a newborn's born, it's not stooling. We're going to check for thyroid. What did I tell you those things we're going to check? Because we're going to be checking them their whole lives to make sure they're getting enough hormones. Because children who don't get enough hormones from birth are going to have cognitive delays and growth delays. So T3, T4, TSH, cortisol is adrenals, and growth hormones is pituitary glands. Okay. How can you monitor a child with hypo or hyperthyroidism? What do we do to look at that? What did I tell you the thyroid does? Simple height and weight. We measure nutrition, we measure hypothyroidism, we measure all of these growth hormones. All of those things are measured. Height and weight, it tells you a lot. Are they growing the way they should? What acid-base alteration would you see in a diabetic child with Kussmaul respirations? Well, that's DKA. So that's metabolic acidosis. Now the body's trying to compensate it. So it does completely the opposite. So if it was metabolic, it goes to respiratory. If it's acidosis, it goes to alkalosis, respiratory alkalosis. Does that make sense to you now? Metabolic acidosis, the opposite, respiratory and alkalosis. The body's trying to compensate for it. And the body does a great job. It's always trying to fix itself. I'll multi-select. What would a child with Cushing syndrome look like? This is an adrenal problem. I went into Cushing syndrome with my rheumatoid arthritis. And I went into it because they gave me too much steroids. The dose was too big for too long. I gained almost 80 pounds and I looked like the Pillsbury Doughboy, just big and swollen. The thing is, with Cushing syndrome, it's an adrenal gland usually that produces these things, the cortisol, aldosterone, but this was the coming from, just taking a pill. The extremities are thin, okay, but you have that pendulous abdomen. You're going to have this hair that grows from places you never knew you could, big ruddy cheeks, and huge, huge weight gains. Now, if you had a kid who was on big steroids, who looked like Cushing syndrome, how do you, especially if this is a child who is an adolescent, give them bigger clothes? Let them be, not like taking a tight shirt, you're always like pulling it like it doesn't feel good. Give them a bigger set of clothing. It'll gonna help them because remember, body image. They want to look good, feel good. I'll multi-select. You walk into a child's room that has a fever of 104.6. You see them having a seizure. What do? Remember, seizures, priority, safety. So check the bed. If there's anything sharp in there, turn them on the side in case they vomit. You're gonna put the head flat. You get the side rails up, try to pad them because you can't do anything but protect them. So it's all about keeping that child safe. And the only time we give these cool water baths would be hyperthermia. Like if they were in a car and overheated or outside and overheated. We don't do this for fevers. Autoimmune disease of the thyroid gland. This is my daughter-in-law, the one with the kid with the seizures. She has autoimmune of the thyroid gland. She has to constantly monitor her thyroid levels. She needs to take her medications in the morning daily to keep her levels the way that they should. And it's called Hashimoto's. Hashimoto's. Autoimmune disease of the thyroid, you don't remove it. You can't, no surgery. The treatment is replacement of the hormones only. And remember, autoimmune stress does affect those levels. So it needs to be monitored quite frequently. Addison disease, another adrenal gland problem. What does the adrenal gland do? This could have something to do when you have a child that is born and you don't ambiguous genitalia because you don't have enough of these hormones. And it's cortisol and aldosterone. So you have Cushing's, too much adrenal, and you'll have Addison's, not enough. How do you treat Addison's? You give them the hormones, the prednisone, whatever they need. And remember, stress does affect it, and increasing the level, giving them more medications at those times is probably what they need. And chronic, you have to keep them monitored really well on their levels. I'll multi-select. A ventricular peritoneal shunt. It's a tube that goes into the fourth ventricle of the brain. It comes behind the ear and there's like a little pump thing there. Comes in front of the chest and it drains into the peritoneum. Why do we use that? It's used for hydrocephalus. Now that little pump there, many nurses want to touch it and push it. Never do that. That's only for the neurosurgeon. Our job with ventricular peritoneal shunt is to look for signs and symptoms of shunt failure, which is headache and vomiting, increased pressure in the head, right? Also measuring the head circumference every shift. So that is the treatment, ventricular peritoneal shunt. Those kids come into the emergency room a lot. VP shunt complaining of headache and vomiting is a priority. These kids probably, they've disconnected or they need a new one. When you grow, that will pull apart. And that's a sign to say, okay, let's do CAT scan, shunt series, get them to the OR, let's get them fixed. A common sign of Graves' disease includes blank or protrusion of the eyes. This is hyperthyroidism. And we're going to give him that PTU medicine, right? And we're going to look out for that leukopenia, that fever, right? And sore throats. Graves' disease is that exophthalmos, those big eyeballs bulging out. Very good. I'll multi-select. Hypoparathyroidism has the symptoms of tetanic muscle contraction and what? Now, parathyroid and thyroid, completely different. They do different stuff. It's still in the same area, but it's different. What does the parathyroid do? Has everything to do with calcium. Now, whenever you think and read questions talking about calcium, magnesium, think of muscles contracting or not being able to contract, okay? So hypo, which means not enough, the muscles are weak. They're not contracting the way they should. There's tetany, and of course, there's low calcium levels. And it could be completely opposite, too much with hyper. So not enough, hypo, and then hyper, too much calcium. And you're going to see that too. I'll multi-select. What are signs of hyperparathyroidism? You know, hypo, what's opposite? Hyperparathyroidism, you're going to see too much calcium, too much in there. So you get that nausea and vomiting from that, and then you get confused with too much calcium. And then you're overspasmed with too much calcium. You have that paresthesia or numbness of the extremities. It is hypercalcium, too much calcium in the body. That was a Hesse question. What does the parathyroid hormone do? After those questions, what does it do? You know this now. It has everything to do with calcium. Okay, good. Which of the following might be a cause of an adrenal crisis, an Addisonian crisis? Adrenals, remember, what is the adrenals all about? Cortisol has aldosterone, but remember, it's just not what the body has inside, it's what we ingest too. And it's getting on steroids and not being tapered off. And it's that abrupt. You could be, I was on 20 milligrams of prednisone for a year. If I stopped all of a sudden, I would have gone into a crisis. It took me 4 months to come off and taper down really, really slowly to prevent it. I'll multi-select. Cardinal signs of diabetes insipidus. I'm going to ask you again. Did you remember what I told you? Remember SIADH fluid, diabetes insipidus fluid, and this is your posterior lobe of your pituitary gland. Polydipsia, polyuria has nothing to do with eating, okay? And you're going to see an increased urinary output. Thirsty, 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 urinate, urinate, urinate. And we treat it with steroids. I'll multi-select. Congenital hypoplasia parent teaching should include, this is the adrenal gland, not giving you enough of what they need. And it causes a child actually to become this ambiguous genitalia. In my lifetime, I've seen one. This child had a vagina and testicles. You know, yes, there was a place for her to urinate, but okay, so your baby's born. So did you have a boy or girl? Well, I don't know, because there's both sitting there. So what they did for this child, and this is the way I learned about this, they did ultrasounds to see what body parts were there. They did some hormone testing, you know, but these parents still didn't know what they had until they decided what was the best choice for this child. So they don't have all the body parts. They'll always be infertile no matter what. Then you need to say, okay, what should we make this child, a boy or a girl? And because the adrenal gland gives all of those hormones they need, they'll be on cortisol, aldosterone replacements for life. And remember, in stress, in any condition, they're probably going to need some more during these times. What causes type 1 diabetes? So I like this thing here. Bob has 36 candy bars. He eats 29. What does he have now? Diabetes. I think that's so funny. But diabetes has to do with the pancreas, the islets of Langerhans, and it has to do with the body saying, no, we don't like you, and it doesn't let it function. So it's a destruction of those beta cells. And autoimmune, my body did it to myself. So diabetes means insulin is not being produced. What does that mean for my body? Well, it means I can't use sugar unless I have insulin. And then my body says, you know, I'm really hungry. I need to eat. So my body goes to other sources and it goes directly to protein. What is the byproduct of protein digestion? Ketones. That's why in DKA, diabetic ketoacidosis, sugar levels are high because there's no insulin. And there's ketones present because my body says, I want to feed myself somehow. I'm going to go to protein. And that byproduct was ketones. Does that make it simple? It's as simple as what DKA is.
Yes, thank you.
Remember, there's always issues with electrolytes, etc. But just understanding that brief concept there, then you could figure it all out, okay? And I've actually seen in my lifetime a glucose of 1100. I've seen a pH of 6.8, and the child made it. How did we do it? We give IV fluids and start immediately regular insulin drip and monitor those blood sugars, get those electrolytes and replace them as per what the lab values are. Yes, DKA is scary, but it can be managed if you understand just that basic why is it happening. So which statement about a pheochromocytoma is correct? These are tumors that come off of the kidneys, and it creates havoc for the person who has it because it's really hard to figure out what's going on. These children and adults have these periods where their heart rate races, blood pressure goes up, and they get dizzy and get chest pain, and they do all this cardiac workup, they do CAT scans, and what it is this tumor is a catecholamine producing tumor, which means sometimes just touching it, rubbing it, or moving the wrong way releases this catecholamine. And catecholamines are sympathetic, which means what? Heart rate up, blood pressure up, and it causes all those symptoms. How do we treat it? Well, we're going to do surgery. Now, once we know this patient has a pheochromocytoma, we know what the symptoms are, so we need to monitor them. We need to have these children, adults, on a monitor, looking at their heart rates, and we need to be monitoring blood pressures, so we know when it's producing those catecholamines, and we can treat it. So multi-select. Which action should the nurse implement in the care of a patient with a pheochromocytoma? Remember, it's a catecholamine, sympathetic. Up, 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 all the vital signs. It's the fight or flight. It's like getting scared, boo, everything goes up. So monitor the heart rate, monitor their blood pressure. Has nothing to do with glucose or sudden weight gain. It is the vital signs. It is like be giving a child epinephrine, same concept. I'll multi-select. Nursing care of the unconscious child include what? Child, adult, treating them, it's the same, it really is. I mean, how do we figure out if a child's getting worse? We're going to be monitoring those neuroscience. We're going to be taking their vital signs and temperatures because we want to know what their heart rates is, what's going on with that. And of course, anything with unconscious has to do with brain, strict I&O, because over fluid in the brain can cause more problems. Pain control, yes, but it's more of the other things that we're really concerned about. Symptoms of DKA are, I told you what you see. We know that there's hyperglycemia and ketonuria, right? So symptoms. So one thing about DKA, and you'll never forget, is when you take a child with DKA, they're pale, they're lethargic. Usually they're in a wheelchair because usually they're that older kid that this happens to. You put them in a room, you close the door. Then you as a nurse go in to assess your patient. There is this in the face, like rotten peaches smell that hits you. Ever put a peach in a Tupperware container, put it in a refrigerator for 3 weeks, come out, open it up, and that rotten peach in the face, that's what it smells like. I'm serious, it's exactly that, because it's that sugar that's floating out in their breath. I'll multi-select. An adolescent has a BMI above 95%, has been urinating a lot. What test can you anticipate? Like, what do you think this possibly could be? But you got to rule everything out, right? So we're going to do a urinalysis. This could be urinary tract infection for sure. Pregnancy has nothing to do with urinating a lot, okay? Hemoglobin A1C is a diabetes. And if you're urinating a lot, we want to make sure that you're not getting rid of your potassium because that could be part of it, okay? Think about it. What are the symptoms? What could it be? And those are the 3 things that I could see. Diabetic ketoacidosis is caused by what? Why does it happen? So if I don't have sugar, my insulin's not giving me those carbohydrates I need, the body's going to go somewhere else, some other ways for energy, and it goes to protein. So you have high sugars, the byproduct of protein digestion is ketones, diabetic ketoacidosis. I'll multi-select. A child's admitted with blood sugar greater than 600 and large ketones. What is your priority intervention? What do you do first? I've already mentioned it, but what is the first thing you do first? There's 2 of them here. I'm going to give a bolus of fluid as quick as I can, and I'm going to be starting this regular insulin drip, monitoring their blood sugars. Electrolytes we'll get to. You're not going to do anything sub-Q with a child this sick. You see 600 ketones, DKA, your pH is probably 6.9. You need to correct that before there's brain damage on this child. IV, fluids, and then regular insulin drip. Monitor blood sugars. A diabetic child feeling jittery. Blood sugar is 45. What's the best treatment for this child? Now, when you read questions like this, you got to look at patient condition. Unconscious, we'll give glucagon, right? But this child is complaining. So that's the difference in these type of questions. What do you see? And we're going to give them orange juice, a glass of milk. We're going to give them the turkey sandwich if we had it, but orange juice is good. If you're out in the public and you have the sugar packet, whatever you can do, get that sugar up on these children. Your patient experienced a head injury. What would most concern you? Think about swelling in the brain. That's a head injury. And understanding that, which here is really, really serious. Remember, you've got things in the brain like pituitary glands, and it could swell. So you could see decreasing urinary output. And that might be your first sign of that injury before they have that not understanding and headaches and vomiting and stuff. So watching your urinary output's important. Very good. I'll multi-select. How do you detect ketoacidosis? So we're going to say ketoacidosis means we're eating protein. So we're going to have blood sugars elevated. So you're going to see ketones in the urine, and then you're going to see 4+ glucose in the urine also. If you're already into ketoacidosis, you already have a high blood sugar. I'll multi-select. What would alert you that a child's head injury, is deteriorating? You know, they've bumped their head and they bumped it hard. They fell off second-story balcony, and you're monitoring them. We had another question earlier about this. Now, tell me now what you think. So you're going to see the child becoming restless, difficulty aroused. It's not just a headache that is getting worse. And it's changing orientation. You know, actually, I could take, the red one too, becoming confused or decreasing their orientation. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? You did the LP. We've seen this white milky CSF. Like, yeah, they got white cells in it. It's bacterial. What are you going to make sure you do first? And that's give antibiotics. Bacterial meningitis is serious. We want to treat it with antibiotics as soon as we possibly can so we can prevent damage in the brain. What is the primary cause of injury associated with submersion? I live in South Florida and I've seen quite a few drownings in my life. But what is the injury we worry about? Because these children, we're going to monitor in the hospital for 72 hours because it could be something that happens later because fluid fills the lungs. They can't breathe. So the primary cause of injury is lack of oxygen, hypoxemia. And they can go into respiratory distress syndrome up to 72 hours later. They need to be monitored really closely. And last question, a multi-select. Which CSF lab value correlates with bacterial meningitis diagnosis? Well, the first thing I see is that milky, not clear cerebral spinal fluid. And I'm waiting for that lab to give me back their report because I want to know immediately because my priority is going to be antibiotics, right? Now, bacteria love sugar, so it eats it up, okay? And then you're going to have an elevated protein and increased white blood cell. It's an infection. It's bacterial. Bacterial does increase your white blood cell. You might see a red blood cell in there, but usually it depends on how good the tap was done. You shouldn't see it. So let's see how we did today. Number 3. Jenny, good job, Jenny. Even after an exam, we did good. Megan, good job. Number 1. We had somebody from another class take over 1. Good job, Mia. Good job. Ulysses and Amber. Please sign your attendance attestation. Get them done. Remember, I cannot give you grades, your absolute grade, until I do a review with my other professors and we get together. But you know, you all passed, so you're all good. And thank you so much, guys. Any questions, comments, concerns, send me my message, okay? And I'm gonna work with you. Great class as always, thank you. Sorry I'm a little bit over time, but you got everything you needed. Have a great
Thank you,
evening.
Professor.
Thank you,
Bye-bye,
Professor.
guys.
Good night.
It's a pleasure.